Well, hey guys, I've got an interesting conversation with an Army doctor, Lieutenant Colonel Steven Schauer, just like the shower. And we're going to talk about some cool things in here. One of them is about vampires. Yes, vampires, taking blood from one human on the battlefield and putting it right into another. We're going to talk about a bunch of other cool stuff that he and his colleagues are working on, taking their time in the Army as docs and making things better for people in general in the world to survive trauma and go on to live longer lives. Check it out on this episode of The Higher Line.
Welcome to another episode of the Carry Trainer Higher Line podcast.
Hey guys, welcome to yet another episode of the Carry Trainer Higher Line podcast. Got an interesting guest today, a medical doctor, Dr. Steven Schauer, like the bathing. He just let me know. You are a lieutenant colonel in the U.S. Army, or you were the last time I looked you up, and you kind of have a very broad background. You're in teaching now, is that correct?
No, so I'm still active duty. That part is correct. I am at a civilian university, at the University of Colorado, the Attributions medical campus. So I'm here with basically an Army-funded civilian education program. So for some certain fields in the Army where they don't have either the ability or the room to train sufficient people in whatever field it is, they'll basically pay for you to go to a civilian university for the education.
Okay.
So in my case here, I'm here for critical care fellowship, which I've opted to kind of go back and do sort of mid-career, which is unusual on the civilian side, but not very unusual on the military side.
So you're kind of going back to what you used to do.
Well, my background is emergency medicine. So I finished that residency back in 2013. And for at least a year when I graduated residency, they were not offering critical care training for emergency medicine. Back in those days, the landscape for going from emergency medicine to critical care is not what it is now. That's since changed. And I decided to go back because I wanted to do critical care back then, but it wasn't available. So I opted to go back and do critical care now, which is why I'm kind of doing it sort of mid-career. So I started my critical care fellowship when I was essentially 10 years out of residency training, which, like I said, from the civilian side would be highly unusual. From the military side, it's not uncommon for people to kind of come in and out of training as they go through their career.
And are you a DO? Is that what I saw? Just tell people about that. I know one other guy that's a DO. What's the difference between that and an MD?
I would tell you, at least for me, on my type of practice, day to day, probably not much different. They have kind of two different, philosophical differences to separate MDs and DOs, and it goes back probably like a century or something like that. Don't quote me on that time frame. But essentially, the DOs try and look at people from kind of a more holistic standpoint. I think medicine in general is kind of trending that direction, but that's kind of the origin of where DOs come from. And a lot of the thought process many, many decades ago, before we were kind of into the evidence-based medicine we are now, we thought a lot of the disease processes started with misalignment of like bones and tissue and stuff like that. And so that's where some of the osteopathic manipulation came from. Now, I think some of my counterparts that work in primary care probably do a lot more manipulation type stuff, the stuff we're taught in school. In emergency medicine and critical care, we don't do it nearly as much, if at all. So that's why on a day-to-day, comparison of me versus like an MD emergency medicine or intensivist, you're probably not going to find any differences.
So if somebody's bleeding to death, you're not massaging their neck, is what you're saying. No. No.
Yes, that's how we get people through their critical illness.
How does a guy or a gal become a doctor in, I guess, the Army? Maybe you can't comment on other branches, but do you go in as a medical professional, or did you go in like everybody else, go to boot camp, and then somehow years later you're a doctor? How's that work?
Absolutely not. If we all had to go to boot camp, you'd probably end up losing about at least half your doctors right through the boot camp process.
Okay.
We kind of have our own separate training pathway. Now, there's a number of different ways that people can come in. Some people are already active duty, and then they choose to go to medical school. And I didn't go this route, so I can't speak to all the intricacies of it. But what happened is they decide to go to medical school. They apply for medical school. They get accepted either to a civilian school, at which point they would go through the HPSP program, or they go to USU, which is the only active duty medical school. And essentially, the military would agree to release them from whatever their current obligation is go to school knowing that they're going to come back to the military on the back end if they're going HPSP. In my case, I went straight through the traditional HPSP route, which is one of the routes that probably most of the physicians come in on, is HPSP, which is the Health Professions Scholarship Program. So essentially, you get accepted into a U.S. accredited medical school, and then you apply to HPSP after you have your acceptance. And they say, okay, yes, we need more doctors. You meet all of our qualifications. We're going to pay for your schooling. And then as soon as you sign your contract that day, you get commission, direct commission as a second lieutenant, non-promotable for the rest of the time you're in medical school. And then when you finish medical school, depending on which branch you're in, you'll go to residency either on active duty side or you'll get sent to a civilian place for residency. The Army trains the majority of them on active duty at military treatment facilities or military hospitals.
Very cool. That's interesting. So I was looking through some of your background. You've done various jobs. So what, during your time as an Army doctor, what'd that look like? What'd you do?
So I did my time in residency from 2010 to 2013, which is emergency medicine at the Burke Army Medical Center, which is the military's biggest level 1 trauma center, their only level 1 trauma center. And that's in San Antonio, Fort Sam. Used to be Fort Sam Houston. That was Joint Base San Antonio. I did that from 2010 to 2013. From 13 until 15, I was at Fort Polk at Bain Jones Army Community Hospital. It's a very, very tiny little hospital that's on Fort Polk, which is now, I believe, Fort Johnson, which is kind of in the middle of nowhere, Louisiana, like truly rural. The nearest big city is probably like, Houston or New Orleans, which are several hours away. And I was the medical director of the emergency department there. So straight out of residency, I basically got thrown into the medical director job, which I knew nothing about and had to learn real quick exactly what my job was. And then also saw patients, obviously, during that time. I had pretty heavy clinical load. And then in 2015, I PCS back to Fort Sam Houston, JBSA, where I was at the U.S. Army Institute of Surgical Research from 2015 until 2023 when I left for fellowship.
Okay. So first of all, they changed like every base name, haven't they? Is there it seems like every one of them's different now. You're supposed to remember them too, probably.
Yeah.
So one of the ways I found you was through Andrew Fisher. And I think some of the stuff that I want to have you share with people is, some of the things that you guys on the Army side or maybe on the military side of medicine are figuring out to save people's lives. For example, something that has now become ubiquitous, like with prepared people, is a tourniquet, right? Post global war on terror, now everybody gets a pistol, a flashlight, and a tourniquet. Now they look the part, throw some carpenter pants on and some cool guy vest, and you've like checked the boxes, which I know it's somewhat become comical because there's so much more to trauma care than a little band of fabric. But comment on some of those things a little bit, how that stuff has changed in 15 years or so that you've been in the field. That's a pretty broad question too.
Yeah, very broad question. The tourniquet era was before I became an active duty. We kind of figured out early in the war, and by we, I mean a bunch of smart people that came before me. Like John Craig is probably one of the bigger names when it comes to tourniquet research, and Mike Dubik, who used to be at the lab that I used to work at, the ISR there, did a ton of tourniquet research. But that was way before my time. We figured out early in the war that what happened was people were bleeding to death because the medic was focused on getting the IV in because that's what they were taught to do at the time. It's somebody's hemorrhaging, you got to get an IV in, you got to start saline. So you're best putting the IV in here. Meanwhile, they're bleeding out down here. We quickly figured out that we needed to stop the bleeding first. But at the time, it was kind of considered like, bad practice to use tourniquets. Like they were still taught as being, an absolute last resort. Don't do tourniquets, they're bad. But then we figured out, okay, if we put the tourniquet on, it stops the hemorrhage. And then these guys started to look at this like more and more in depth. And they're like, well, okay, how long can we leave the tourniquet out for? And then we had cases that were getting reported out further and further and further out. People that had tourniquets left on for crazy amounts of time, stuff that would have been considered insane back in like the late 90s. And they did just fine. Because they stopped bleeding and they could survive a long time with that tourniquet on without really causing a lot of long-term issues. So that was really before my time. Probably the first thing that came really into use as I would start to become on active duty was the use of ketamine, which was also kind of like a crazy idea back then. The idea of using ketamine, low dose ketamine for pain, back when I was a resident, was kind of like a very new thing. So new that it really was not even accepted into practice yet. The idea of doing it was kind of a very, very novel thing. And so back when I was a resident, I had the opportunity to work with one of the staff at the time, actually two of the staff, a guy named Josh Miller and a guy named Vic Barta. And we did the first randomized controlled trial comparing ketamine to morphine for acute pain. And this is very early in the stages of ketamine, but you look now in 2024, like everyone's using ketamine. It's a common
Sure,
thing now.
paramedics are juicing people up with it every day.
Yeah, and so that was a thing that has kind of evolved just in my career among many other things that have continued to evolve.
Is this just something nobody looked at because it just hadn't been looked at yet, or was there some negative that was believed to be attached to it that it wasn't investigated or looked at further?
I think one of the biggest hindrances, and there was data back then before then, some data, a very small amount of data from like the anesthesia literature looking at this. But the biggest problem is that ketamine, the only labeled indication for ketamine is induction of anesthesia. And in the hospital, nobody ever used ketamine outside of the setting of procedural sedation. And in order to use it for procedural sedation, you had to be like a credentialed person to do procedural sedation, which is very limited. So you're talking like anesthesiologists, emergency medicine, and intensivists. They're going to be able to do procedural sedation. And then when you use it, you got to have all kinds of like paperwork signed and paperwork ready to go and documentation and monitoring. And so there was this idea that if you were giving ketamine, you had to like do all these things that was associated with procedural sedation. And it took a very long time to kind of get over that mentality of having to consider like low dose ketamine a separate entity from procedural sedation. And so that was one of the biggest challenges in trying to get ketamine into practice. And then, if people are only using it in the hospital for procedural sedation, you got to be credentialed to do it. The idea of a paramedic doing this in the back of a truck was just like, insane at the time. If you ask a lot of people, but now that we finally kind of like broken down that barrier that, low dose ketamine is not the same thing as, complete snowing simple ketamine. Now it's become common practice where we can kind of move that out into other areas of medicine where previously would have been prohibitive.
Seems like I'm sure it's in a lot of fields. People get fixated on a certain idea or topic, or they accept something. Dogma, I suppose, would be the word. I've got an M1 Garand. I recently shared a video on our YouTube channel. I was digging through my ammo stores trying to find some ammunition to shoot the M1, and in that pile of ammo, I found a really old box of 30-06 that was like down $10 or something. So I was like, oh, that's cool. Like, and I remember where it came from. It had the sticker on it. It was 30 years ago, 25 years ago. And it was 220 grain ammunition. I'm not like a historical guy about this particular subject, but hundreds of comments. Never shoot that in the gun, you'll break it. And it's like dispelled long ago that you can shoot this ammo in the gun. It isn't going to hurt anything. But I got people sending me messages. People sent me emails like, bro, I don't want to see you ruin that gun. And it's like nobody goes out and does the research. They just repeat the same shit over and over and over and over and over. And it's like, well, and then they cite they're citing discussion from somebody else that doesn't know anything. It's crazy. Seems like medicine, though, it's even worse.
Oh, it's definitely worse. It's definitely worse. I mean, these numbers have been kind of all over the place. People have quoted that it takes anywhere from 15 to 20 years from the time a scientific finding happens so it actually like really permeates practice. It's quite crazy how long it takes for us to like take lessons learned and like implement this into practice.
What was the guy's name? Immelweis, was he the guy that figured out that the germs were coming off the doctor's hands and as they were doing autopsies and then going into the birthing room and they were passing on disease? So he's like, maybe we should wash our hands. And the guy ends up in a mental hospital out of his mind because like they found that the data was correct. And then they're like, to hell with this guy. I want to go play with dead bodies and then touch babies. And he ends up locked up. Was that his name? Immelweis? Does that sound right?
I looked that one up. The story sounds vaguely familiar, but as for the name, I couldn't tell you.
And it wasn't that long ago. It was like 100 years ago. The dude's like, maybe we shouldn't touch dead bodies, and it took years and years and years for them to figure that out. Okay, so ketamine, got it. It's taken years now for them to sort that. I've been through the EMT program numerous times in my life. I did it once when I was a kid. I did it like 6 or 7 years ago at the local college, real low level basic stuff. And we, working with some Green Beret 18 Deltas for years, have taught TCCC through a couple of courses. And it's, I guess I would say basic stuff, the medical side of it to a guy like you, definitely basic stuff. But I'm in like this accredited program at a community college made up with doctors and nurses and all of these folks that see this stuff every day, day in and day out, and they're looking at some of this new stuff in the textbook. This must have been like 6 years ago, and they read it because they had to, and then they would tell the kids. I was older than many of the instructors. They said, "Yeah, but don't do this stuff. Don't do this stuff." And I'm like, I can't say anything as I'm sitting there, but I'm like, how ridiculous is this? Now there's this whole batch of all those kids are paramedics now riding around on ambulances. Told, don't do this very well-tested bleeding control techniques and measures. Just let people die and pump them full of fluids, washing their blood out onto the floor of the ambulance. It's nuts.
Yeah.
So
that same thing for World War II and from Vietnam, and it came right back around. It took forever for us to get rid of that.
So you were in a hospital. You've got EMS attached to the hospital. How is it like at your hospital where you've got paramedics bringing people in and they're working under the care of the doctors in the hospital, right? Or under the supervision. How does it differ in that type of environment versus all these civilian hospital systems?
Are you talking about comparing like the military hospital to the civilian hospital?
Sure. Yes.
I would tell you it's very similar. The only difference is the clothing that people are wearing when they're walking around at work. For the most part, you're going to have the same kind of relative standards that people have to adhere to. They still have the same state licensure stuff. The military treatment facilities are still primarily civilian driven. The military people there are still the small minority of staff that are there. So you're still going to have the same uphill battles you're going to have with trying to change practice there.
Let me rephrase that question. So like just this specific item of tourniquets, traumatic bleeding control measures. Are you guys promoting these best practices that the military's kind of sorted out on the battlefield, or are paramedics still being taught some of the arcane, older techniques and technologies?
I hope in 2024, no one's being taught to not use tourniquets pre-hospital. I think that has penetrated so far out now. We even have stop the bleed kits everywhere. I really hope that that's not a thing that's still being taught. If you want to talk about something a little more recent, I think pre-hospital blood is probably a little more recent thing that still isn't widely used. That is still kind of making its way out there. We still have a lot of services, probably most services actually, that are still using crystalloid, despite the piles and piles of data we have from the deployed setting and from the civilian setting showing that blood products are better. But that is one thing that, if you're looking at things that still haven't penetrated their way out into EMS, that the military's been doing for well over a decade, I think that's probably a more recent example of things that still haven't made their way through.
You presented on that. I've looked at some of those presentations. Talk a little bit about that. So what is this protocol you're talking about? How does it differ from past protocols that were accepted?
If you look at like the old school ATLS and still kind of what's being taught now based on ATLS protocols, as you look at, patients hypotense, you're supposed to give them 2 liters of crystalloid and determine whether they're kind of a fluid responder or fluid non-responder. If they're a fluid responder, then you consider giving them blood. But by that point, you've already given them 2 liters of crystalloid, which is enough to like sufficiently dilute someone out. 2 liters of crystalloid is
so not everybody's a doctor here, so their blood pressure is super low. That means they're probably bleeding, and then their blood's being diluted with crystalloid, which is what? What is that material?
Water, salt water, or some other form of water that has some electrolytes mixed into it. So you can think of crystalloid as like a glorified medical version of, say, like Gatorade minus the food dye and the sugar that's in there.
Okay. So your suggestion, instead of pumping people full of that, is literally human blood, warm blood.
I mean, in terms of the best option is, warm, fresh blood, almost straight from the donor. So I'm bleeding really bad. I need blood. They come to you and they're like, hey, you have the same type of blood this guy has right here. How about we do a real quick screen to make sure there's nothing communicable, and then we're going to draw a bunch of blood off here, usually about 500 cc's worth. And then while it's warm, fresh, straight from the donor, straight from the manufacturer, nice and fresh, they come over and transfuse it right back into me. That's the ideal product. We don't do that here in the civilian setting. We only do that in the military setting. So in the civilian setting, we do kind of one of two things. For the most part, most places are still doing fractionated products, which basically means you go to a donor center, you get screened to make sure you don't have any high risk type of things that would preclude you from donating. You donate a unit of blood, so you give up about 500 cc's worth of blood. That blood gets screened for some, communicable diseases to make sure there's nothing there. And then it goes off to a processing facility where it gets fractionated into several pieces. So it get fractionated into like your packed red blood cells, which is just red part of the blood. Your platelets, which is the stuff that kind of helps you clot. The plasma, which is like the liquid component that has a bunch of important stuff in it, but is more kind of watery looking, kind of like a dirty water looking type stuff. And then the white blood cells, which is your immune system, which kind of gets filtered out and thrown in the trash. And then those pieces will come to me as the patient who's bleeding, and they'll start to transfuse those pieces back into me. Likely in kind of the same ratio that it was donated in. Some of the newer centers are doing what's considered low titer whole blood, which is basically whole blood that's uncross-matched, but can be given pretty much to most recipients without any issues. Like, yeah, you can pretty much universally give it to almost everyone, minus a very few instances. In that case, you would go to the blood center, you would donate the blood, they would determine that you have very low titers of specific antigens that they're looking at. And if your thresholds are below that and you have type O blood, then they're like, hey, we're going to just leave this as is in the bag that it came in right here. And then when I'm bleeding as a patient, they just bring me the whole bag of blood that you just donated that they screened, and they hang it up and they infuse it into me. So that's kind of the what trend is moving towards probably the past at least decade or so, is to use more of that and less of the Powerade or Gatorade for, restoring my blood volume after I bled.
Do you think that at some point we'll be able to make some synthetic or man-made product that will be able to do the same thing? We just have it on the shelf and just go grab a B positive bag of some stuff that's just sitting there. Will we be able to do that, you think?
I believe we will eventually get there. The question is when that's going to happen. I think we're a ways off. People have been looking at these things. They're called like hemoglobin-based oxygen carriers, which are essentially like semi-synthetic blood products for decades now. And we're not much closer to what we were back then. We just don't know how to make some of the pieces, at least in totality. We can kind of make some of the pieces of blood products. Like we have some recombinant factors that are essentially, semi-synthetic products that we use for very, very limited indications, like very specific disease processes. But for the most part, we haven't figured out how to like replicate the entire blood product. So I tend to think we're more likely to have some sort of like modified animal product available before we're going to have truly synthetic stuff available.
Interesting. I didn't even think about that. Here's a question I like to ask guys like you. So nowadays it's become in vogue to go out and get pistol training and stop the bleed or TCCC or maybe some martial arts training. I do practice all of those things myself. If you were to sit down, you've got family, loved ones, I'm certain, that are not medical professionals like you. If you were able to sit down and like grab a notebook and say, okay, Dr. Steve's going to tell you all the stuff that he wants you to know in a specific order, what would those things be? Like, does everybody have to be able to like cut somebody's throat and shove a pen in there so they can breathe? Like, is that super important? How about, like, I'll let you kind of making a smart ass comment there, but you get my point.
It really depends on what it is I'm trying to get across to them. If we're talking specifically about trauma, I mean, the biggest
Average
thing
people. So your aunt, your uncle, your neighbor, and it like if you could just plug into people's brain like some stuff, and they had some time, not just 10 minutes, but they were going to dedicate themselves to learn some stuff. What would you have people be investing some energy in?
I mean, I would keep it super simple. I mean, all we're talking is your CABs. Stop the bleeding and help them breathe. So if you could stop the bleeding through either teaching them how to do proper pressure dressings, how to hold pressure on a wound, how to get a wound to stop bleeding through those methods, using like things like quick clot, very simple type stuff. If they could apply a tourniquet to some sort of extremity injury. Now, extremity injuries we don't quite see in the civilian side nearly as much as the military, just because the nature of like body armor and stuff that we're wearing. But if you could teach them how to put a tourniquet on, which is very simple to do, if you could teach them how to use like a BVM, that's very simple and easy to do. All stuff that's essentially going to be available in like a stop the bleed kit or an AED kit. Enough stuff to kind of get them by for like the key things to keep their brain alive and keep their heart functioning in some sort of like, some sort of physiologic method until, somebody else has got more training can arrive. That's really all you need. You don't need some crazy techniques you're using with some like, administering some drug combination. We don't need any of that stuff. You just need those very basic things. I think to get through probably most of the stuff until someone else has got more training and more equipment can arrive. And literally, like that happens right in front of me. That's probably all I'm going to do. Like I'm not walking around with an emergency department in my pocket. I'm not carrying a CT scanner around with me. There's no CT scanner in my pocket. So literally all I'm going to do is keep doing those things there until someone else has got some more toys shows up to move the process along.
What do you think about when you see some of the stuff that's sold to non-medical professionals, like very expensive, multi-hundred, multi-thousand-dollar training or not training medical kits? What do you think about some of that stuff? What's that make you think of?
I'm not sure you're going to use most of that stuff for. I mean, most of that stuff is not going to have much of a use, at least during the first few minutes. Like I said, all you're trying to do is bridge the gap for when somebody else has more equipment to get there. I'm sure which equipment, Pat, you're talking about, but
there's just so much stuff out there. I mean, you could drop $10,000 and buy a huge Pelican case that has got all kinds of very advanced stuff that belongs on an ambulance or in a crash cart. But guys, I've got some of that stuff, but I only carry things that I know what I'm using it for. Most of it's just bleeding control stuff. I always keep an AED because of the nature of what I do and how often we're in kind of remote places. We've always got an AED and oxygen, but you can buy some pretty freaking crazy stuff that people sell, and people are happy to buy it. People are happy to buy these very expensive medical kits, and you open it up. I mean, I've got a small one here I grabbed out of the truck. This is an 18 Delta created this little kit. This is pretty basic shit. Airway, burns, bleeding, bandages, splinting. Got some drip drop in here for when you've not been drinking enough water, shit like that. But basic stuff. But there's some stuff out there, guys. You go on the internet and find some crap that's $5,000 and
Zoll monitor.
Say that again, please.
Your own personal giant Zoll monitor that you carry around.
Yes.
Yeah, I mean,
something I noticed. Go ahead.
Yeah, there's nothing I'm going to be able to do with that information, even if I had some sort of really fancy monitor with me. There's not much, here in my living room that I'm going to do with it anyway. So I'm not sure what I would do with that fancy monitor. I don't really need all that stuff necessarily. If I was going to carry any kind of monitor with me, which is, when I do, it's going to be a very simple thing like a blood pressure cuff and like a pulse oximeter. It's not something anything super fancy.
That makes good sense.
My living room.
The longer I've been alive, the more I've seen this same thing happen. I was just with some guys this past weekend. One of them comes from the highest echelons of Navy special operations, spent years there, a couple Green Berets. And these dudes are like walking around with flip-flops and $50 in a billfold and, sunglasses in another country where we were. And then, some medical guys like you're talking about. I used to travel around with a dude. He's since left us. 18 Delta, excellent dude. His name was Joel Gupton, and Joel's vehicle had stuff in it. He worked at Bragg and their medical training department after his time was done being deployed. And same thing, flip flops, a 6-pack of beer. Like he always said, your greatest resource is resourcefulness. Like, but maybe you can act that way when you've got a body of knowledge in your head. I've done the Heimlich maneuver twice on real people. And I remember the first time being like, holy crap, I'm going to break this old lady's ribs. She was a tiny little 80-pound thing. So it's like in my head, when somebody like you that does this professionally every day, day in and day out, sees ambulances pulling up to the hospital and, it's got horrible things to deal with, you, through that exposure, have some level of composure. How does a person develop that when it's their kid who's blue and lifeless on the side of the pool, or freaking smashed up in a car wreck and blood's leaking out of them? Like, that's the part that I find harder to help people understand and wrap their head around.
I mean, the best thing you can do is repetition. I mean, doing something over and over again is where you kind of drill in your head. As a lot of people said, people don't, rise to the occasion, they fall to the level of training. So if it's something you've done over and over again, it gets to be much easier once you've done the same thing over and over again. I mean, it's no different when you're like a brand new doctor and you have something very sick, you're like easily overwhelmed. You're like, oh shit, what do I do here? Until you've done the same thing over and over again, you kind of have your own like mental checklist you go through each and every time. And then when you're not sure what to do, you kind of just rerun the same checklist. After a while, it becomes, second nature to kind of do it, where you can do it nice and calm and everything like that, because you've done this a bunch of times and you have it down to like a very simplified format. I mean, if you have a sick patient in front of you, you're not doing a lot of like really complex thinking at that point here. You're kind of like starting out with the simple stuff, doing the simple stuff over and over again until the simple stuff has kind of got you to a point where you can start to like rethink your way through stuff.
Do you use visualization in your training, or did you when you were a newer doctor?
Oh yeah, and I still tell people to do it now. I mean, there's nothing. The most common example I tell people is that the first time you're coding a patient as an intern, if you're the first person that's there, pull out your ACLS card and just look at your ACLS card and say, okay, step 1 is do this. Step 2, okay, make a decision, yes, no, go left, go right at the ACLS card. And that's exactly what I tell them to do. I mean, there's absolutely nothing wrong with doing that. And so you kind of drill that into your head and it becomes second nature. But the first few times, the first few or dozen or whatever it happens to be, pull that card out. And even in some places, like even in our trauma bays at BAMC, which is the biggest military hospital, only level 1 trauma center, we would literally have this stuff up on the walls. Like we have all the algorithms up on the walls. We have like dosing of commonly used drugs up on the walls. So even a place that's like a well-greased trauma center where we see, 5,000 plus trauma patients a year, we have very simple visual cues up on the wall to remind us of what to do for like algorithms for dosing, that kind of stuff.
So you don't have to remember all that stuff.
No, I mean, eventually after you've done this enough times, you can kind of like estimate your stuff for like drug dosing and stuff like that. But we still have the aids up there. So it's still not uncommon. You're like, okay, this drug that I haven't given in a while here, you're either going to whip out your drug guide here and look it up, or you're going to look at the thing on the wall. I mean, even now, there's not a single shift that goes by that I'm not looking up the dose of something or looking up some sort of aid for memory tool. I mean, there's no way you can memorize all this stuff here. So there's nothing wrong with using like visual aids and stuff like that to kind of prompt your way through the thinking process.
I would prefer you did too, especially if it's me that you're sticking needles in. go make sure. So you've been doing this for a while. Is it different than what you thought it would be? Is it all you thought it was going to be?
I mean, there's always stuff different than what you think it's going to be. You certainly go into medicine with one image, and then after you've been practicing for a while, you kind of have a different image. I think I'm at the point in my career where now you have to really, fight to stay interested, fight to stay like hungry for knowledge. Really try and find ways to make sure you're like enjoying what you do, so that it doesn't become like repetitive and you don't feel like a cog in the wheel, which is probably the hardest part, I think. After a few years out of medical school, you start to feel like you're a cog in the wheel sometimes. And so kind of like fighting that urge and fighting that sensation, I think becomes one of the harder parts of medicine.
I'm seeing like this trend just in guys I know. I've got a handful of doctor buddies. I don't know exactly how old you are, but you're probably around my age. And I'm seeing dudes like leaving. Like one of them, he was an 18 Delta, went on to become a doc. He works in Florida and does he's a gastroenterologist. And he's going to leave and he's back in school now to become a psychologist, to work with guys that have PTSD, because he's just so sick of the bullshit with insurance companies and like hospital systems and all that kind of stuff. Is that kind of something you see pop up?
Oh, it's very common. I mean, emergency medicine has consistently led all medical specialties in terms of like burnout rates, And the number of people that want to leave the field after a decade in practice, emergency medicine is always in the top three in terms of burnout. So I definitely see that a lot among my colleagues. I think that's the hardest part, is really kind of like finding a way to stay interested in your medical career, and trying to find a way to like feel energized when you come to work every single day, which I think is a challenge for a lot of people.
What's crazy is how much you guys work, but you would never tell your patients to do what you do. Sleeping a couple hours a night, cortisol levels through the roof, blood pressure spikes every hour, like how can you make the argument to do that? Like, why don't we just get more people into that field so you guys can go home at night and go to sleep?
So I think that's changing quite a bit. I mean, what I think as I was coming into medicine, we were starting to see that kind of mentality already like phasing its way out. Obviously, emergency medicine was one of the early adopters of kind of a shift-based mentality. Back in the old days of emergency medicine, you used to have these like on-call doctors. They were essentially like random doctors, like dermatologists or something like that. They would have to cover the emergency department. But as emergency medicine became its own specialty, we started to see more and more kind of shift-based mentality. And now we're seeing that quite a bit more across a lot of different fields that you probably never would have thought you would have previously. I mean, even a lot of our surgical specialties are now very shift-based. Our trauma and acute care surgery and emergency general surgery type services, those are now very shift-based. They're not working these kind of crazy hours anymore. You're starting to see more and more of that become shift-based. Critical care is becoming much more shift-based. So you're not having people working the crazy amount of hours they were before. So I think it's just kind of as society has changed, medicine has very slowly started to adopt that. And I think we've lagged behind a lot of other fields, but I think we're starting to see that more and more now.
Okay, I like that. That's a good thing. I found you through Instagram. What's the purpose of you being on social media? What do you utilize and leverage that platform for? What message are you trying to get out to the world? Or are you trying to find
Yeah, primarily use
like me to send you messages?
I use X or Twitter a little bit less, but more so Instagram. I started doing that with Andy, Andy Fisher, as kind of a way for us to kind of get out some of the research that we were doing. There's this one co-resident of mine that used to refer to research as just kind of like asteroids out in outer space, that there's a whole bunch of asteroids floating around, and then every once in a great while, two asteroids will collide. And most of the time, you just look at the crap floating around in outer space, you don't really know what to do with it. And so I was trying to find a way to like kind of get some of that stuff out and kind of more the mainstream. And so the thing is, there's like a lot of stuff that we're doing that if you ask the average like medical person in the military, whether that's like the average physician, the average PA, the average medic, they're gonna be like, I had no idea this stuff existed. What are you doing? What's the point of this? And so for us, it was kind of a way to kind of get some of that stuff out into kind of a more general audience that may not necessarily read some of these like obscure medical journals we're publishing stuff in. I doubt there's very many, medics that are out there reading the Journal of Trauma and Acute Care Surgery on a monthly basis, or the Annals of Emergency Medicine on a monthly basis. So, some of the stuff that we find either we're working on, or other stuff that we find very relevant within our field, it's a good way to kind of get it out into more of a mainstream audience. That's kind of why I started doing that.
So normally that would be punched out into the journals. Doctor would get a copy of that sent to him back in the old days. Now it's probably all email, and you sit around in your free time between patients and peruse the journal and go, oh, I didn't know about that. I didn't know about that. Maybe you'd run into somebody at a convention and see them give a presentation on it. You're utilizing the social media to actually put out what you're finding to be best or better practices and some of the stuff you're working on. Is that correct?
Yeah, I mean, even the average physician probably only gets, I'm guessing, one or two journals a month at most. And so, I mean, there's a lot of different emergency medicine journals out there, a lot of different trauma journals, a lot of different critical care journals. Nobody's subscribing to all that stuff. You can't. Number one, you can't read it all. Number two, there's costs associated with it, so no one's going to pay for all those things. And so otherwise, unless it's in like one of the very mainstream journals that everyone's picking up and reading, you're still not going to get that information disseminated. And then whatever stuff is going in that journal is kind of whatever the editorial board finds relevant from their perspective. And so sometimes it's still kind of hard if you're not really into digging around in these like journals and stuff like that to find relevant stuff. You may not come across the stuff. And so I happen to find entertainment sometimes and digging through some of these journals and looking stuff up on PubMed that is relevant, I think, to my day-to-day practice or day-to-day stuff I'm interested in. And then when I find those things, I try and kind of like disseminate those things in sort of a digestible format. I mean, most people are not going to pick up the papers and, slice and dice and read all the fine print about the statistical methods. And most of them probably don't have like training on how to read that stuff. And so that's kind of why I try and do a quick digest of this and like something very simple, take home point and whatever it happens to be. So
what is the general consensus of the people following you? Are these people not finding this information elsewhere? Like I'm going to use the word comical, but it's interesting to me. We do a similar thing. 10, 15 years ago, we were using YouTube to disseminate better practices in some of the firearms training. And I've had guys that run state police academies send us messages telling us we're going to get people killed. And, this is not even anything off the wall. This is like very basic stuff that now 10, 15 years later, those academies are teaching, not because of me, but because it's taken 10 or 15 years for people to just kind of absorb, like you're talking about the overall idea. But it's funny. Funny is the only word I can find, that guys are having to go to social media platforms, medical doctors, to disseminate information so that people fucking see better ways to save people's lives. That's nuts.
yeah.
That's nuts. Do you get any pushback from management? Anybody in like the medical field that's like, hey, why are you putting this stuff out on the internet?
Not usually. I mean, every once in a while I'll have an opinion about something that may be kind of the lesser opinion, the more minority opinion that every once in a while I'll get some questions about, but very rarely. I mean, most of the stuff I'm putting out, I think, is really just taking the current literature and sharing it. And so a lot of times when I get questions about it, I'm like, oh, hey, actually, maybe you should read this paper here. And then I send them the paper and they're like, oh, that totally makes sense now. Why have I not been doing it that way? So I'd venture to say that's probably more of the questions I get. Every once in a while you'll get some troll on there that's just looking to start like an argument with something like that. But for the most part, I think most of the comments I get are not related to trolling. Then the other thing I like to see is I get a lot of comments from the medics just asking questions like, why is the military investing money in some of this stuff we do? And so since that's
why are they not investing money? Is that what you said?
no, why are they? I mean,
Why?
sometimes the question is also why are they not? I probably get the why are they not question more than I get the why are they. But I mean, I've spent most of my career in military medical R&D. So I have a pretty good finger on the pulse of like what stuff the Army's investing, or that shit the military as a whole is investing in from a medical standpoint. And I mean, when you think about the life cycle of a project, from the time I submit the grant till the time I have like the publication out there, you're talking at least 5 years. And so there's a big lag between when those things happen. So I get a lot of questions sometimes like, why is the military not looking into this? And I'm like, well, actually, the military is looking into this here. They funded this study here. But oh, by the way, it's going to take 3 years to accumulate enough patients to get enough data. And then they have to analyze the data and publish it. They're like, oh, well, I didn't realize you guys were already looking into this thing that's totally relevant. I look forward to seeing whatever the finding is in 5 years, or the clinical guideline change in 5 years. So those are a lot of questions I'll get to is why are they not doing this here? And it turns out we are doing a lot of that stuff. It's just that unless you're in the R&D community, you're not going to know where the military is investing money. You don't know that stuff until the publication comes out years and years later.
I find it very interesting to read the comments on these things you guys post, and then look at the vast differences that the people that are out in the field could be some bleeding control thing, or like there's a couple of trauma medicine guys that'll post like signs and symptoms, and they don't tell you anything else, and then guys are like, all right, I'm going to administer this drug in this fashion, and then somebody else is like, I would never do that, this is going to cause this, and you're like, shit, these are all the guys that are going on calls, and like, here's two dudes with the same information, and then they've got like two totally different responses to the information and data that's being presented. Like, that's friggin' scary to me.
Yeah, the hard part about some of that stuff is you're operating on such like limited information on whatever small little blurb they've given you. When in reality, in real life, there's like a lot more data points you're taking into account when you're doing stuff in real time, life. And so that's why those are like those boards questions where you're like, what are they getting at with this boards question? It's just because you're not taking in as much data as what you really would in kind of a real life encounter. And also, some people just like to argue. I mean, there's
People do like to argue. People do like to argue. I actually just filmed a video today, kind of musing on the fact that people go to the internet, like somebody will watch this video and they will just create an argument out of thin air. And it's like, what's your goal, man? Like, is your wife mad at you? Is she cheating on you again? Why are you angry at me and Steve? We didn't do anything to you.
It's like every now and again Instagram that says, for this post, just go start a fight in the comments.
There
and
you go.
We're trying to start fights over it. It's essentially what some of it is, I think.
I grew up with a guy. I won't say his name, but I've told this story before. When we were teenagers, one time we're going to go to a movie. He puts on his mother's ski jacket, which this was the late 80s, early 90s. And it was like this crazy, like hot pink and like chartreuse green ski jacket, a lady ski jacket. And he zips it up and then he puts on his mother's Reebok sneakers that had like the two Velcro strips up top. They were the high tops. And super tight acid wash jeans that they didn't fit, but they were skin tight. And he goes and just walks in circles around the outside of the movie theater smoking cigarettes until some guy was like, said something like, what the hell are you wearing? And the guy peels the jacket off and proceeds to get in a fist fight with this dude, just waiting. I mean, that was trolling before the internet. I'm like, what the hell are you doing? Like, you literally just goaded some guy to comment about your idiotic clothes, and then you beat the guy up. That was pre-internet trolling.
Yeah, now you can do it. It doesn't require as many days to recover from, obviously.
There's people that will go years trying to find these people too, just to like somehow bring the thing to a fruition. You talked about R&D a little bit. What kind of stuff were you working on R&D?
We've got Andy's one of my biggest collaborators. We've got a number of projects that are going on right now. I think the biggest one we're getting close to wrapping up here is we did a big study looking at number one, calcium derangements on arrival to trauma centers. Number one, number two, kind of what happens to your calcium level over the first 24 hours as we're resuscitating you, and how do all those numbers jive into what's going to happen to you in terms of like your survival at 24 hours. And to give you an example of how long that's been going on for. We are just now, it's 2024, we're just now wrapping up all the data extraction. We started this project back in 2019. We first submitted the grant to the granting agency as a pre-proposal. Then we got selected for a full proposal, submitted that in 2020, then got selected for funding, then started the process of the study. And then, oh, by the way, COVID happened. So a lot of research got shut down that was not COVID related. And here we are now, 5 years later, just wrapping up the data extraction. That's also turned out to be a huge pain. It's been harder than we thought to get all the data we want out of the EMR system into a format we can analyze. So people have been asking these questions about calcium for a long time, and calcium and trauma, calcium derangements. And so, when people ask you, why is the military not studying this? Well, we are. It's just, this is how long the process takes.
Can you go back a step for us laymen? What the hell are we talking about with calcium? I drink my milk, which I don't. That's disgusting. I'm not a baby cow. But so we're talking shock. Somebody coming into the ER.
So somebody comes in, they've had some sort of major trauma. They've been shot in the abdomen multiple times. They've gotten to a major car wreck or something like that. And now they've got, an injury to their liver, injury to their spleen. They've injured their lung. They're being brought to the emergency department. There's things that we've known for decades are bad. They portend a bad outcome. So if the patient comes in cold, that's not good. If they come in really acidotic, meaning that their acid levels are very high, that's not good. And if they're bleeding and their bleeding clotting is not working very good, we know that's bad. We call this a lethal triad. And then for years, we were talking about the lethal triad of things that would happen. And when you saw those markers in a trauma patient, you knew that there's a good chance they're going to have a bad outcome. They're not going to survive. And then there was more and more data suggesting that there's like more to this. Maybe your electrolytes are getting out of whack when this is happening. And there was a whole bunch of electrolytes that we've looked at over the years that other people before me have looked at. And the one that kept on popping up all the time in literature was calcium, that people would come in after getting mangled up from some sort of injury and their calcium would be all out of whack. Most of the time, their calcium would be low. And then if their calcium is low, is that bad? Like, are they more likely to die in the next 24 hours? Does it really not matter? Can you just give them some calcium and then fix the problem? And then they won't die in 24 hours. It's kind of the questions that keep coming up. And a lot of the studies to date have been relatively small studies. They've been retrospective, meaning that we just kind of go back and look at some charts and say, okay, yeah, when Mickey came in, his calcium level was low, but he lived. And you kind of do that a bunch of times over and over again. That's like a chart review. But there wasn't good data that was collected like in real time. And so what we proposed to do in this study is that every patient that came in the trauma bay, as soon as they hit the door, they would get a calcium measurement. And why is it important? Well, a lot of times we start to resuscitate people, we give them blood products, which also jacks up their calcium levels. As you're infusing blood products, it naturally causes your calcium level to drop because the preservatives are used. So the question we were trying to primarily answer, among several other questions, is how many people have a jacked up calcium value just because they're mangled up from where their trauma is before we even pour the blood products in. And then, oh, by the way, when we pour the blood products in, it kind of makes the problem worse. And so we got to kind of stay on top of this. So that's the question we've been trying to answer for years. And now we've kind of got to that answer. Now that we've had this study funded and now we're kind of getting all the data out. Now the question is just.
It's a super simple metric that you're trying to attach some values to give you a portal into the outcome of the patient. Can this one number tell us a lot?
Yep.
So the other electrolytes, they don't have this same weight, or they've been looked at and the data is just not there?
No, there's been a number of electrolytes that have been looked at. I mean, potassium is probably the biggest one that's been looked at, and that really hasn't shaken out as being anything really that correlates or is associated with their 24-hour outcome. And then same thing with like magnesium's been looked at as maybe related to that. But the thing is, we know that calcium is involved in a lot of it. It's a factor involved in a lot of how your blood clots. You need certain levels of calcium for your blood to clot properly. But if your calcium level is too high or too low, it's also bad. And so calcium kind of made a little more sense, at least in terms of coagulopathy, like your bleeding problems, in the setting of trauma, because we know it's involved in a lot of your clotting that happens, which is important for trauma. If you're bleeding, you need to clot.
So 5 years you've been at this. Where are we at now in all this data? What's your? I've seen that you've spoken on this. You've got some posts up about the topic at hand. Like what's the current state of this data?
We are almost done extracting all the data. So we actually ended up enrolling more patients than we initially anticipated just because of some design challenges. We ended up enrolling actually substantially more patients than we anticipated. So as a result, we had quite a bit more data to pull out. We also thought going into this that we were going to have these data extraction tools from the more modern EMR systems, electronic medical record systems, that would automatically just like spew the data out for us and we could just kind of analyze it, which
so you guys were all excited drinking beers going, this is going to be so easy. We're going to push.
It turned out to be way harder than we thought. So we're almost done extracting the data, a lot of which had to be kind of manually extracted or had to be computer extracted and then reconfigured a bunch of ways. So we're almost done with that. But I can tell
Doc,
you
how many patients? Was it like 8 people?
For our primary analysis, which is calcium on arrival, I think we're going to have somewhere around like 900.
Okay.
So a pretty large sample size. And we're talking sick patients. We're not talking people that came in. It's not a sample of a bunch of people that drank all.
These are people coming in off ambulances that are in a bad way.
Yes, they had to meet our for the 3 institutions involved, they had to meet our criteria for what we consider the highest level trauma activation. So they had to be like in shock. They had to have like major bones broken. They had to be intubated. They had to have chest tubes. They had to be the sickest of the sick to get into this. So our sample size is not being diluted here with a bunch of like non-sick twisted ankles or anything like that.
So what's the data telling you? Are we just going to start eating calcium pills on the way in on the ER or on the ambulance ride?
I don't have we don't have the final numbers yet, but I think one of the things that's going to be a little bit surprising is the fact that we went into this with the thought process that if people came in with low calcium, that low calcium was bad and they were going to have bad outcomes compared to people that had normal calcium or eucalcemia, kind of a way of saying like normal calcium. And it turns out that is the case. I mean, we are seeing that, at least based on our preliminary analyses, that patients that had low calcium, they did bad. It turns out there's also a subset of patients which we totally did not expect, which is that there's some patients coming in that have high calcium values. And we don't really have a particularly good reason for that, other than potentially you have like bony tissue breakdown because they're more critically injured. There's probably something with the parathyroid that happens that stimulates calcium release. But the patients that have high calcium do even worse than the ones that have low calcium. So I think what we're going to find in our final analysis.
I'm sorry. No, go ahead. I'm sorry.
I think what's probably gonna shake out of this is that you got to do what you can to keep their calcium kind of in the Goldilocks range, where you have like not too little, not too much, and you got to keep it right in that sweet spot there. So this initial idea of like, well, low calcium is bad. Let's just have them drink a ton of milk here, so their calcium levels are always high. Is probably not gonna pan out to be good.
So keep it in the range that it's supposed to be in, so their body's in a good state to repair itself and have the processes work as they need to.
Yep.
That's super cool. Has there been any pushback from the medical field on any of this information?
Like I said, our first publication will hopefully be coming out around the springtime, so we'll see what kind of feedback we get then.
But
That's
you're
always
talking about it.
Yeah, but it's a little different when you're just talking about it in a conversation format, and all I've presented to the audience is like limited snippets of it. I don't have the full data set. It's always a little bit different when you actually have the full analysis done. You have very detailed information about how you did the study, so people can critique your methods. There's always critiques in every study. There's no such thing as a perfect study. There's always critiques. It's just a matter of how science works. And so it's different when people look at the full format of that. And also, there's also been other data that's come out since that time that people are going to kind of take into account. So I'll be kind of excited to see what kind of feedback we get. Certainly once hopefully the paper comes out in the spring, full publication, we'll get some feedback from other people as well as how that may or may not change their practice.
Super cool. So when this is all done, this could be like a pretty legit feather in your cap of your career.
Yeah, I mean, my number one goal is always to figure out how to make our guidelines better, because your guidelines is kind of what obviously we try and use to guide care. And so if whatever you're doing is not somehow like improving the guidelines or answering some sort of clinical question, then it's just not very motivating. And so, I try and find stuff that, number one, I'm interested in, number two, stuff that's going to be relevant, and number three, obviously stuff that the granting agencies will fund us to do. And so, hardest part is finding something that fits all three of those things.
That's really cool. And I'm just thinking about all of the different factors that got to go into all of that. It's pretty daunting. So 6 months, a year from now, you think you'll have some kind of definitive paper on it?
Optimistically, I would say sometime probably late spring, we may have something out. Of course, I said this thing was going to be done, over a year and a half ago too, and then we ran into all these data extraction problems. So here I am.
It's like you're a contractor. You got a bathroom remodel timeline going on.
I just need a little more time.
What other cool stuff are you guys working on?
The other one that we've been pretty excited about is we developed basically kind of a training module to teach medics how to do warm flesh blood transfusion. So basically how to do a buddy transfusion. Special operations has been doing this for years. The Ranger Regiment has been the first unit that really led the way in terms of doing like point of injury, warm fresh whole blood transfusions or buddy transfusions. But trying to get that out Army wide has been quite a bit of a challenge. And especially, it's very hard, especially when you have a whole group of medics that have already been trained trying to learn that skill, as opposed to newbies that are coming in. You can just simply bring that into the part of their training as part of their core curriculum, and they learn it as they come in. So what we had got funded to do was develop a training module, basically a video that walks you through it from beginning to end, along with like checklists that tell you step by step exactly what to do. And so after we developed those two things, we took that to a whole bunch of medics that had never done this before, and basically tried to figure out like, okay, is this training video and the checklist sufficient to be able to get them through the process here so they can actually learn the skill? And so, one of the things we looked at, number one, is like the success of it. So how many times just by watching the video and doing the checklist can they actually achieve the endpoint, which is like doing a whole blood donation and transfusion? Has been one component of it. The other component has been just going to these guys and basically saying, okay, this is a brand new skill that you're learning. These are all perishable skills. Tell us more about how often this has to happen in order for you to become like, very proficient at this and maintain a high level of proficiency. And so that's been one of the other kind of projects I've been working on that's wrapping up here pretty soon. Is doing that project across lots of medics. And then we've had the opportunity to actually go back and retest some of these medics again, like months later, somewhere between 3 months and a year later, and then find out how many of them actually like retain the skills and the knowledge, and how many of them can still go through the process from beginning to end. and then kind of ask them like, hey, how rusty do you guys feel? How often have you done this training? And they're like, well, one guy over here says, oh, my unit started doing this all the time. I feel great about the skill here. Go to another medic over here, and this medic is like, well, actually, the last time I did this training was when you were here 9 months ago. I don't feel very good about this skill. And trying to get an idea there is how we need to like train this particular skill, which would obviously inform a lot of the other training we do with our medics, which is, how often we need to kind of go through those repetitions in order to like, number one, obtain proficiency, and then number two, like, maintain that proficiency. Those are two different things.
So this is a exigent circumstance out in the field. One guy is giving blood right out of his body into the patient.
Yeah.
So is that?
Well, no, it's not really going like there's not a tube connecting me from you. It goes from me into a bag.
A lot cooler if there was.
Yeah, that's actually been experimented on, but there's a whole lot of problems with that, which I won't get into. But they've been I've been pre-screened that I don't have the communicable diseases. I get re-screened on a regular basis to make sure I haven't picked up, like hepatitis or syphilis or something like that.
So you like have dudes that are on each team or unit, and you're like, okay, Bob's the blood guy. If we need somebody, he's been tested a bunch.
Yep.
Okay.
Yeah, and then one of your medics has to go draw the blood off Bob, and then give the blood to Mickey, who's got injured and needs the blood. So it's what became like was previously kind of like an extreme thing that only happened in extremis. We're trying to make this more mainstream, so that when people are actually bleeding out and hemorrhaging, every medic out there can do this.
Okay. Well, I'm O negative, so I'd probably be the Bob guy if as long as my blood comes up nice. So you can't just plug one into the other, man. I've seen it, I believe, in some movies. Just like flex up a little bit and
A little bit. Have you sit a little bit higher up there, so gravity kind of brings your blood down a little bit?
go in, artery on my side, venous on the recipient side.
That would certainly help it flow a lot faster. It might be a little painful for you when I stick that needle in your artery, but
My concern would be, how do you know like how much you've given? You got little flow. I'm getting dizzy. Can we stop now?
Flow meter or something like that, which we don't have. You'd have no idea how much is going to person be.
So we don't do that. You got to go draw it out, measure it, and then you know what you're dealing with. Okay,
Yep.
That's cool. So you created this training video. The interesting thing is I've heard of this. So how were people learning about it before? Was it just doctors sitting around just conversing with medics? How has this information been passed on in the past?
The few units that were doing it initially, they would just have one of their physicians that was there or PAs that knows how to do it, basically teach them how to do it and take them through the procedures. And then it started to become part of the curriculum at a couple different, very limited number of courses. And so that when the medics would go through those courses, they would learn the curriculum and they learn how to do it. And then ideally they would take that knowledge back to their unit and then kind of train their people how to do it and keep their skills up. But now it's become a standard for all 68 whiskeys, which is your Army combat medic. It's become a standard training for all of them that are going through the pipeline coming in the military now. So now you have these new guys that are coming in, new guys and gals that are coming in, 18 years old, straight out of high school, coming in, learning to be a medic, and they learn how to do this procedure. And then they go out to their units, and now they have these old sergeants that have been there for a while that are like, oh, I never learned how to do this. And now they got the new guys teaching some of the older, guys and gals how to actually do this procedure, which has been the hardest part, is getting them out of their units where their senior leaders don't even know how to do it. So, and just trying to find ways to out to them.
What is the name of this technique?
Well, it's called a warm, fresh whole blood donation or a buddy transfusion, or the official term is an emergency donor panel. That's the official NATO term for this. The method that's used to train the medics is called an autologous blood transfusion. Autologous just basically means I donate my own blood, then I receive my own blood. There's a whole bunch of medical reasons that we actually do this in medicine. So if I know I'm going to have an event or a surgery that's going to be bloody, and I have a very specific type of blood or some issue with receiving transfusions, sometimes the best thing for me to do is donate my own blood. They take it, they put it in a fridge, and then on the day of surgery, when I'm having a lot of bleeding going on, they pull my own blood off the fridge and give it back to me. That's when it's used actually in medicine. For training purposes, we're doing it right in the spot. I'm donating a unit of my own blood, so the medic is practicing getting blood out of me. Then they process the blood bag the way they're supposed to and analyze and check the blood bag the way they're supposed to. Then they give me my own blood right back. So that's how they learned all the process of basically obtaining the blood of unit and infusing it into a patient is by me donating a unit of my own blood and getting it right back.
So they're just doing this to each other in school.
Yes.
Okay. And then isn't there another name that you guys call it in like internally that I've heard?
I've always called it autologous blood transfusion.
I thought I heard Andrew call it something else. Maybe I'm mistaken. No matter.
I'd have to ask him. Maybe he's got some other secret term I don't know about.
I'll look at my notes. Is this something that will eventually bleed over into mainstream medicine, like rural maybe? Also, like my sister's a wilderness EMT up on an island in Maine.
Yeah, I mean, the wilderness medicine community has obviously had an interest in this. A number of trauma centers. There's a couple trauma centers in the country that are trying to get approval to do something like this. So for one, type specific blood donation and transfusion is not like an approved thing right now, and I'm not aware of any trauma center that does it here in the U.S. However, there's some that are trying to get this. So the idea behind it is not that every single time you have a trauma patient that comes in, you would pull blood out people. More so, the idea is that when you know your supply is about to get exhausted. So, for instance, some mass shooting happens or a big accident happens, and your trauma center is now overwhelmed with the number of patients that are coming in that are bleeding. It's you can burn through your blood supplies pretty quick.
Okay.
Which 1 or 2 patients not a big deal, but if you have 30 that are coming in, that may be a problem. So the idea is that you could potentially have this happen at some of the bigger trauma centers. You could just simply call up your emergency donor panel people or text them or something like that and say, okay, mass casualty, can everyone come in? And then if I'm a donor, I'm like, oh, I see my text message here. I drive to the trauma center and say, hey, I'm one of your donors here. They do a quick screening and they find out, okay, I've got, O positive blood. Boom, they can draw my blood off and start giving it to someone right in the spot. And so, if you had 100, 200, 300 people that were on your roster, you could easily send a mass text message saying, everyone come in, we need your blood, and you can get on the spot, as opposed to right now, if your trauma center gets low on blood, you got to start calling around other places in town and be like, hey, we got a catastrophic bleed here. We need, these type of blood products, and hopefully someone has it. Same thing goes for
say that last part again, Doc. You broke up for a second.
Oh, the same thing goes for rural places. So rural hospitals have very, very small amounts of blood on hand. You're not going to go to a rural hospital and find a rural hospital that has 100 units of packed red blood cells on hand. They may have 5 or 10 or 1 on hand. They may have no platelets and stuff like that, just because they don't burn the product as fast, therefore they don't get as much product. And so if it's bleeding really bad, it goes to a rural hospital, you can exhaust their blood supply in a matter of an hour. So that's where it has benefit to more wilderness or rural settings where you can potentially call people from the community and be like, hey, come in here and draw blood. I need to get your blood here. The only way I can get blood is by flying 2 hours to go pick up more blood. We need this stuff now. And so there's a lot of interest in this and trying to develop this. And I think this will happen. This will happen in my career. It's just a question of when.
That's super cool. Vampire, was that what I was thinking of? Is it the Vampire Protocol?
Yes, Vampire Protocol. I don't recall what that stands for. That was a specific training program that they used. They called the Vampire Program. And then since that time, the Vampire name has just kind of become it's become like the Kleenex of this. If you were to apply like a Kleenex name to autologous transfusions, Vampire would be one of them.
Okay. It's probably not like a really friendly term too when you're thinking about what's happening. The medical terms are better, not a monster sucking your blood out of you while you're dying and sick. That doesn't make good sense. It's kind of stuff, even with my very limited understanding of it, it's super cool to talk about. What's cool is the amount of resources that go into trying to make this stuff mainstream. Like 900 patients, and unfortunately I'm sure some of those people didn't make it, and then how many other ones came into the emergency department that didn't fit the criteria, and that's a massive amount of work to take this one little tiny slice of medicine. You got people working on so many different fields. It's cool that you guys are pushing the envelope on it.
Yeah, there's always more questions that I want to answer than I have available resources. So, it is exciting to do, but I've sort of got a lot more questions I would like to answer. But
What resources would you take if they were available? Financial or manpower or both?
Well, I mean, the financial spills over in your manpower. That's really what funds your manpower for these studies. So I pretty much all do clinical research, meaning I'm doing stuff like human subjects in one way, shape, or form. And you got to have personnel to do that. You got to have like adequately trained personnel. So you got to find personnel that are good at this. You got to be able to train them on how to do the procedures for the study. And so there's a lot that goes into it. So I mean, the financial part is what pays for your personnel essentially, and that's what you need more of. There's almost never such a thing as too many of them, especially as the projects grow in complexity and stuff like that. And then just by nature of doing studies, I mean, you can't schedule trauma patients. It's not like you're doing a cancer trial where you can call them and say, in 2 weeks, you'll got your training. You essentially have to have like 24/7 plans because you never know when they're going to show up. And when they show up, you got to be ready to go.
Can you crash your car next Tuesday at 10:15 a.m.? Yeah. Yeah, that doesn't.
Bring you to my hospital, not the hospital across town.
Are you partnering with other hospitals, getting data from them?
We are. So this particular study was 3 centers. We have another study that just launched. That's a 2-center study. I mean, so you could probably do a lot of these studies at single centers. It would just take you a lot longer. It also kind of limits your generalizability when you only use one center because certain types of things only happen in certain types of the country. Where you have more trauma centers involved, it gives you more generalizability. Because now we have trauma patients from San Antonio, from Denver, and other places, and so then it kind of gives more applicability to more patients in more places because you've taken slices of each place's population and included them. It also allows you to get enrollment done a lot faster. And people obviously want answers now. I can't get answers now, but if we can get you an answer in a year, a 1 year, 2 years, 3 years instead of say 10 years, that's much more advantageous.
I like it. Probably having that broader slice is probably good where you're not looking at patients all at one altitude or living in one climate. You probably get some changes because of some of those things too that could create some issues with the final numbers, what people are eating in a certain area, or am I just making shit up?
We obviously don't have cold problems in San Antonio. We're really not having an issue of people freezing to death in San Antonio. Your trauma patients aren't getting cold in San Antonio, really. But here in Denver, people are definitely getting cold. You wreck your car, you may be stuck for a while.
Right. What are some things that you would pass on to listeners? Maybe, nobody likes going to the doctor, right? Unless you're getting dick implants or something, which I've never done. But you go to the doctor and you complain. I got a bunch of friends I told you that are doctors. My dentist buddy, I'm always breaking his chops because I'm like, I know that you sit me down and then you go watch YouTube videos for a half an hour while I wait for you to come back. What's some stuff that like the general public doesn't know about the medical field and like that you'd like them to know?
I think the most frustrating part is there's not a lot of appreciation to the stuff that happens when I am not physically present in your room. When I'm physically present in your room, that is like an ultra small slice of what I'm doing on a day-to-day basis. So I think a lot of people have this perception that nothing is happening with their medical care if I'm not sitting in the room with you face to face. But in reality, that's like a small fraction of what's actually happening. So
You're planning your next golf outing. You're booking airline tickets to
Amazon shopping, trying to figure out the next time. Yeah.
So, go ahead.
Yeah, I mean, so there's a lot of stuff that happens when I am not physically sitting in your room. So that I think is one of the more frustrating parts, especially about emergency medicine, is we see people. I'm talking to them for maybe 5 to 7 minutes at most, and then the rest of the time they're like, "What the heck is this doctor doing? I've been here for 3 hours now." Well, it turns out that I had to go in there. I had to order some stuff in there. I had to actually go through and interpret all your labs. Once the labs came back an hour later, after interpreting your labs, I determined that, okay, you need to get a CT scan. Okay, you need to get an ultrasound. Okay, I actually need to call this consultant here to get some input. And so then I had to page the consultant, sit there waiting for them to call me back. They call me back. I discuss the case with them, and they say, okay, we need to get an MRI or something like that. And then after discussing that with them, then I put the MRI in here, and then I discuss the MRI that I'm looking for because I want something very specific with the radiologist. Radiologist protocolizes it. You go get the MRI. Then the information comes back. I've got to interpret that information here with all the other stuff going on. Meanwhile, I've talked to you like a whopping like 7 minutes during that time, but this whole process has taken, for my time alone, 30 minutes of my time, but you've only seen a small slice of that. And so a lot of times with very complex stuff, there's a lot of stuff that's happening that people don't realize that. That for me is one of the more frustrating parts, is how much people don't realize there's a lot of background stuff that's happening.
I was doing clinicals a number of years ago at the local emergency department, and there was a young PA that I guarantee slept no more than 2 hours a night. And I used to come grab him by his shoulders and like hug on him and, yank on him a little bit. He was a nice dude. This is probably 10 years ago now. He just ground it out, man. He'd be at his computer and he'd get up, take like a big hit of coffee, and then go walk into a room, and I'd be with him a bunch, just doing whatever he told me to do. And I thought, man, this dude is just breaking himself down trying to get all this stuff done. But I'd see him in his office at his computer with, paperwork everywhere. And it was nuts, the amount of stuff that he was trying to do. And he'd be like, God, I got to go take a piss. Like, I've been having to take a piss for 2 hours and I've not been able to stop by the bathroom. I remember one time in particular, I told him, I'm like, you go take a pee. I will go tell them that you're coming. And I went and told whoever was in the room, like, Doc's on his way. He'll be right in. But like, he just, and like a million doctors and nurses and physicians do, just can't working to try to help people. So you get a bunch of angry folks every day or week. The hospital's not fun, man.
No, there's a lot of frustrating parts. And I got to be honest, being in the military, I'm a little bit spoiled that I don't have to deal with all the stuff that my civilian counterparts do. I do work in a civilian setting. I do work, part-time off-duty employment, back when I was in San Antonio. So I definitely saw a lot of the civilian side. But like in the military, we're not having to deal with like prior authorizations. If I have a soldier in front of me that needs something, we just kind of like do it without even thinking about it. Like, they need this, I just order it. It just happens. I don't necessarily have to get all the prior authorizations that all the civilian physicians have to deal with the frustrations with. So, while you wonder what's taking so long for your doctor to get the MRI, well, it's because they had to go back and forth to your insurance company 3 times to justify this thing. And that's, like I said, we're getting a little spoiled from the military side, and the fact that for the most part, like, if they're active duty, I don't got to do that stuff. We can just
The insurance companies ruined medicine, the insurance industry. Ruined.
Yeah, I think burning people out too, especially people in primary care.
Say that last part again.
That's especially, I think, a major burnout factor for people in primary care. I mean, I think primary care fields like internal medicine, family medicine, pediatrics, they're the ones that have had to just bear the most brunt of dealing with the frustrations of insurance companies. And that's why that's why a lot of those people are not going in those fields. There's less applicants for those fields, less people that are staying in primary care, more that are subspecializing and going into fellowships, is just because that part is so frustrating.
Yeah. I know a couple of guys, it seems like half their day is just billing, trying to fight to get paid. Just had a guy at a class. He owns he specializes in Moe's, and he said pretty much half of every day is, how do I get paid for all the work that they're doing? Just trying to fight with all the insurance companies and the companies telling them, we'll pay half. Or the thing that you did that we told you we'd pay you for in the last week, we decided we won't. That's nuts. Anyway, I'm sidetracking. I really appreciate you taking the time, man. I appreciate your service to the Army and the U.S. Population as well. I always ask guys when they come on the show, what would you leave people with if they never cross your path, if they never run into you on the street, if they don't ever meet you? What would you leave them with? Doesn't have to be about work, can be about anything.
I would tell you, find something that motivates you, and then find something that keeps you happy, and try and find a balance between those two things.
Beer and wet t-shirt contests. If I could just do like, I'm just joking. But that means
you can buy the beer at the store, so you got that one.
I haven't seen a wet t-shirt contest in 30 years. I don't even know if they still do them. But I like that. That's kind of I was just watching a documentary on a flight the other day. This guy is like the biggest researcher on glaciers in the history of mankind, and he spent 30 or 40 years coring glaciers at this glacier that's like at 18,000 feet in the Andes Mountains. Nobody's ever done it. He gets congestive heart failure during this time. He can't barely walk. He's still going up on these glaciers and got a heart transplant and did like 10 more years of this. It was a fascinating story. With it's up at 18, 20,000 feet with somebody else's heart in him, coring glaciers. And it was just so dedicated to this thing. And like, kind of like his whole life was just digging in the ice, but he was just so passionate about it that even with a bum heart, he still kept doing it. He's like, fuck it, I'll just die up here because I'd rather be up here than behind my desk at the university. I like it. How do people find you? What's your Instagram account?
Army EM doc. So like Army emergency medicine, but like emergency medicine, but Army EM doc.
Army EMDOC.
Yep.
Perfect. I appreciate you, man. I know you're busy. We scheduled this, I think, like 3 or 4 months ago. So thank you for taking the time.
Yeah, thank you.
Hope you have a wonderful Christmas. You guys that tuned in, hope you learned something. I did a ton. I got some notes here actually on some stuff I want to go read on with all the things that Doc talked about. Be well. Don't be dickheads. Tell somebody you love them, and go out there and tell the doctors in your town thank you for all the golf that they do and fishing trips and yachts and sports cars that they get with our money. That was a joke, man. That was a joke. I appreciate you, man. The rest of you guys, be well. Don't be dickheads. Tell somebody you love them. Signing out.
Visit our website, carrytrainer.com, for information about classes held throughout the U.S., Carry Trainer apparel, and upcoming projects. You can also email us at training@carrytrainer.com for information about setting up your own private course or speaking engagement. Training@carrytrainer.com or carrytrainer.com.